Now to the very other important topics of extended range of vision IOLs. So Dr. Bala is going to share that with us.
Zoom, share screen. There we are, share. Hello, everyone. My name is Chandra Bala. I'm an ophthalmologist in Sydney. If at any point you can't hear me, if somebody could let me know, because it's a bit hard to do it online. I am a consultant for Alcon, J&J, Hoya. I'm going to share with you our experience with Vivity as an extended depth of focus lens. As you're aware, there are many IOLs out there: accommodative, refractive, diffractive, pinhole IOLs, and the latest kid on the block is, of course, the wavefront shaping technology introduced by Alcon, which manages to shift and stretch the wavefront in the central 2 millimeters of the IOL. The concept extends to this idea of a light tunnel in the middle. A monofocal IOL has good distance vision, but tapers off towards the intermediate. Diffractive IOLs tend to have peaks and troughs, whereas by having this new wavefront shaping technology, you're able to create a long, thin pencil of extended depth of focus, which allows you to see far and intermediate quite well, and sometimes even a fraction of near. Keeping that pencil tight and narrow means that you don't have that much scatter outside the intended focal point, and therefore you get less blur, halo, and glare with this lens. I had the pleasure of being the chief investigator for the OUS study of Alcon's, and the lens is a wonderful lens. It is based on the same platform as SN60 wavefront, so most people are completely comfortable with the lens. And it's a non-diffractive technology, which has also changed the way people have been thinking about it, with a central 2 millimeter annulus and a 1.1 micron elevation from the background. So it's not much, but for what it does have, it punches well above its weight. This is the defocus curve, and I'll draw your attention to the fact that it's fairly flat from 0 to 1.5 diopters. And so it, given its vision at all points during that range is better than 6.9, people get excellent quality of vision as is expected from an EDOF within that range. Now, there are two types of doctors out there. There are the non-refractive doctors and the refractive doctors. The non-refractive doctors who have just come to this concept of presbyopia correcting IOLs have heard a long story of diffractive IOLs and glare and halo. And apart from the price point being an issue, it is also an issue of once you've implanted, you don't want to add more chair time to your life. Often the non-refractive doctors don't have such pristine patients with pristine eyes, and they want to consider monovision, mini monovision. And so the cohort of patients is different from a refractive doctor who tends to get more pristine eyes, and they are sitting in the world of trifocal IOLs. And for them, it's a different set of challenges as to why, say, they should put a EDOF lens and what to do in post-myopic cases and in very high myopes. So we have a whole lot of both types of doctors in our practice. There are 12 doctors who are operating. Of those, only the 2 who are circled there are refractive doctors. We as a group have been doing presbyopia correcting IOLs for a decade, but only 2 doctors have ever done them in the form of trifocal IOLs. The rest have never touched a trifocal IOL or a bifocal IOL. And that's an important point to remember, because in 2019, the 2 of us were doing 8% of the whole lot was panoptics. 92% was non-panoptic cases, where monofocal lenses only. In 2020, when Vivity became commercially available, that number gradually picked up. And by 2021, half the cases that we were doing, which were about 464 Vivity lenses were implanted. And that too, that number was small because the range was limited. The lens suddenly became very popular with every doctor, refractive or otherwise. And on average, everybody was getting around 6.6 with N8 for 50 centimeters. And if there is a take-home message in there, it is this change in surgeon behavior. And the second take-home message is that 6.6 N8 shows you that you've actually nailed the lens in the correct place for that particular eye. I just want to quickly play a 1-minute video
shocked. I wasn't expecting to develop cataract at this age. But once I realized that that was the problem, it was really clear that it was impacting on my ability to see. I was cleaning the operating microscope constantly, feeling as if it was blurred, but it wasn't the microscope, it was my eye. So the colleague who did the surgery for me, Dr. Chandra, Bala, is a refractive colleague, and he does use a lot of multifocal intraocular lenses that people like Dr. Chandra. The reason being that we do a lot of very close work, a lot of reading, but I was very put off about having one of those lenses because I'm aware that some patients are doing things like halos and glare afterwards. We spend an awful lot of time in the dark room with bright lights, and those multifocal lenses sometimes are problematic, for example, night driving. A lot of my work is in very similar lighting conditions. So I was absolutely adamant that I really wanted to avoid because of those bright side effects, and that what I was most interested in was clarity of vision. So that moved the discussion onto extended focus lenses, and that was much more appealing to me, having looked at the data. So I made the decision to go ahead with surgery very quickly, and in fact have the operation a week later. It was a little odd to do the patient.
So Angela had a posterior subcapsular cataract, and if you look at her numbers to the left, you can see she has a little bit of monovision, about 1 diopter. And as Angela mentioned, for most doctors and lawyers, I really encourage them to go for a trifocal IOL because of the amount of reading they do. But Angela was completely adamant. She was a medical retina specialist, and she would not accept that. So the choice was to go plano, or to go slightly minus so that she could get some reading. Slightly minus because Vivity would perform, you could take advantage of the flat defocus curve and get more near vision for her. So, sorry, I'm trying to go to the next slide. She had uncomplicated cataract surgery. We tried a 22.5, aimed for -1/4. As I said, we just wanted to get a little bit more near. And interestingly enough, she got 6.4.8 and N5 for near. Which was quite a surprise. We waited for a month to see if that would change, but luckily for me, she got an excellent result. She was between eyes, it took us about 4 to 6 weeks to operate. So during that time, she was driving. She would drive 400 kilometers to a couple of the clinics, and she would report to me that she could see one halo, and that never seemed to bother her with her night driving. Then the question arose, what to do with the second eye? Do I aim for -1? Or do I, again, consider mix and match, or do we go for plano? So I demonstrated what it would look like, and Angela had never had excellent distance vision. So she chose to go right ahead with distance Vivity again for the left eye. I won't play the video. She did very well, and binocularly, she sees 6.3.8 with the Vivity IOL. And this meant that suddenly all the doctors in our practice became very comfortable with the idea of implanting an EDOF lens like Vivity. And so came the new boom, and people like Angela herself was comfortable implanting it into other people's eyes. And so this is a case of an 83-year-old patient who does not have a pristine eye, has excellent, had 6/12 vision. The retinal structure, you can see that the photoreceptor layers are still quite intact. There are drusen underneath, but we felt that it was still worthwhile. The patient got 6.9 and N8 for near, and so that gives you a lot more functional vision, at least for the moment, till the macula deteriorates. Even in glaucoma, if you have, this is a patient who had a Grant's hemorrhage, has had a field loss in the left eye. The patient is -2.5 in one eye and -4.5 in the other eye. And so we took opportunity of the fact that the patient has an isometropia. And again, excellent vision, 6.6 and N8 for near in the contralateral eye, where we left her slightly myopic. Diabetic retinopathy, we've had extensive discussion with the patient and consented them, because you can see the whole page of consent form there. And again, the patient does very well with even in proliferative diabetic retinopathy cases. In refractive surgery, of course, it's a different ball game. The counseling process is much longer. You have to spend more time to explain what can be expected and what cannot be expected. Here's a patient who is -3 myope. And a patient like this, I would always be reluctant to do a trifocal IOL, largely because I would aim for distance and the near vision was never as good as a -3 myope would expect. So in this case, Vivity was a much better choice. We aimed for -1.5. This way, at least the unaided vision picked up from 645 and 660 to 612, and the patient is still able to see very well for near. And so you can customize the treatment depending upon what the patient actually needs and what the patient wants. We've also done mix and match with ultracert. This patient had an ultracert in one eye before and was -1.5 in the other eye. Eventually, they developed a cataract in the contralateral eye, and we decided to do an Vivity on the other side, and the patient is seeing 6.9. We left this patient slightly myopic and can get N6 for near. And this is one of the beauty of the Vivity lens, is if you do have an isometropia and you want to try mini monovision, and if you choose -0.5 asymmetry between the two eyes, you don't have to really worry about ocular dominance with this lens. Post-refractive surgery, you will remember the EDOF, the depth of focus, the defocus curve was very flat. Here's a patient who didn't know whether she had hyperopic or myopic LASIK, but the pentacam showed that was most likely a hyperopic LASIK. This is a wonderful lens to take advantage of the long landing platform. And so even if you make a slight error and you aim slightly hyperopic or slightly myopic, the distance vision often tends to be excellent. And we managed to get, again, N8 for this patient with 6.6 and 6.9 for the right and left eyes respectively. We know that aberrated corneas are not somewhere where you would put a trifocal IOL or, because the amount of scatter that Samaresh mentioned, the scatter starts at the cornea. Here's a patient who had a large scar over the cornea. I peeled it off. 3 months later, we rechecked the topography. Things had changed dramatically. The higher order aberration in the cornea was still at 0.174. The Q value was at 0.3. Remembering Vivity is an aspheric IOL, most of the time we would have been comfortable with 0.5 as our upper end of higher order aberrations. But we did one eye and then the second eye, and he again was 6.6 and has been spectacle free for the first time in 60 years. As I mentioned to you before, the Vivity is based on the SN60 platform, and only the central 2 millimeters of it is different. Here is a patient who had a Vivity implanted, and at that time, during surgery, there were some issues with the zonules, and unfortunately, the patient didn't receive a capsular tension ring at that time. By the time I saw the patient, he had lost his near vision. At best, he was at any one point seeing N14. He was seeing double, not from the Vivity itself, but the fact that he had a refractive error. And I was able to get him to 6.6 with a subjective refraction. I then put a with ring segment, tied it up, and he again reached 6.75 with a small correction, and suddenly his reading returned. So even if the lens is defocused, you're not going to have the same issues as a trifocal or a diffractive IOL, where you get a whole lot more glare and halo because of the defocus, as well as because of the external rings on top. So my tips, if people are wanting to start on Vivity, is first, expect 6.6 and N8 at around 40-50 centimeters. They expect to advise them to wear about +150 at nighttime, especially if they want to read in bed. If the far is 6.6 and the near you did not hit N8 and it is less, then it's likely you have had a hyperopic outcome and you would repeat a subjective refraction pushing plus. If you're after monovision, an anisometropy of 0.5 is easily acceptable. Ocular dominance in that case is not important, and I can assure you 2/3 of your patients will be spectacle free for all tasks. If you aim both eyes for far, you can expect about 1/3 will be spectacle free for most tasks. The lens is safe in AMD. If retinal thickness and photoreceptor architecture is good, we haven't done a full contrast sensitivity study, but if those are good, then I think your patient will still benefit from a Vivity. Contrast sensitivity was not a problem in the original trial, and therefore we felt quite confident in using in glaucoma cases. The tip for refractive surgery, if you want to secure a endpoint, you should take advantage of the Vivity's flat defocus curve, because that way you will, more often than not, most likely you will somehow get a good unaided distance vision. If you do have decentration, don't worry, it'll automatically behave like a monofocal lens, and you can deal with it the same way you would deal with a monofocal lens. Thank you very much.